one of
You're on the record now.
on a on a patient on Monday, and so I haven't actually seen the patient, but the description is she started with a boot camp, usually often starts with a big workout, and has high hammy glute, like buttock pain that referred a little bit down into the thigh, then has spread up across the SI joints and into the other hip. And the therapist that asked me to consult said she's cleared the lumbar spine. We'll see. But so I'm thinking ahead, and we do have somebody who needles here, but she's only gone through, I don't know, phase 1 or the first training. So I'm not sure if she gets into those muscles or not. So that's what I was asking.
Okay, with her, what it'd be is you're looking at, that's where I would look in here at the stability or dynamic stability of the SI joint. So you learn how to kind of look at the dynamic assessment of the hip to see if the hip is internally rotating and standing, if she goes into single leg stance. Okay. So, I'm expecting her problem to probably be hopefully somewhere in there. She about mid-30s, early 40s?
Yep, she is.
Yeah. Okay.
Early 40s.
Okay. If she had children too, then again, there could be some underlying, just recruitment patterns in the pelvic floor. And the muscle tone changes as you age because you start to lose testosterone and lose some muscle tone in the pelvic floor. But I would look for hip tone transfer. My guess there is that if she's looking at trying to get stability through the hamstring to stabilize the pelvis for load transfer, it would probably be one of the things I would expect to see. So like in standing, when you look at the hip, I'd palpate the biceps femoris and see if it has extra tone while she's standing. Is it just kind of the one side just more toned than the other? And as she shifts her weight left and right, you can feel the glute. The glute should come on relatively same time or before biceps femoris. Her biceps femoris is kicking in, then she's using it as a stabilization strategy instead of glute. And since that's going to come up through sacrotuberous ligament, stabilize SI joint, it could be a secondary stabilizing strategy she has, which isn't atypical in that population of females to see. So she's going to be hip femoral head centering is what I need to know. I need to know, can she control the SI joint as she's moving? And again, in there could be the whole spectrum where she could be muscularly compressing it at times, but then when she transfers weight to it, it's unstable. So keep a very open mind as you look at the data and take what it gives you, and don't second guess yourself if you find that, wow, if she feels hypermobile and unstable when she's standing and she does the weight shift test, but when you do a supine assessment, it feels stiff and stable. It could just be that she has adequate muscular shunting when you do the supine stability tests. But when she's standing, the body weight is enough to overcome it, so she loses control. And she goes to a hamstring strategy. Okay. That's what I would go ahead.
The other thing we know about her is tender sacrotuberous ligaments. That's the only other thing I know. Yeah, that was where she was most tender, was up in the sacrotuberous.
Yeah. And I used to think it was something, and now I know it isn't. Now I know that, just because the way the biceps femoris blends up in there, it's the way we transfer the load through it and how it's trying to control the innominate. It's not a primary injury. If anything, you look at the hip rotators, which are attaching underneath of it, or it's referred down from lumbar spine. But when you have the pain in there, what you'll find is that if you palpate the sacrotuberous ligament, but let's say you take the sacrum and counternutate it and put it on slack, the pain will go away. So that's where you look for hamstring tension. Do I have innominate rotation? I tend to think of what is stressing, putting extra undue stress through this ligament that I need to address. And I don't get caught up in that this ligament is the primary. I need to treat the ligament. Because
when you say femoral centering, are you talking more the EUFR type thing?
Yeah, you think of the EUFR, and I know when I first learned it, they taught it as this individual thing, like you have the EUFR or you don't, right?
Yeah.
Well, that's not the case, and just about everybody, you're going to find that the hip can center anteriorly. So many people have an anteriorly translated hip from breakdown of the labrum, chronic standing patterns, but they aren't lacking the posterior glide. It's like somebody with a lumbar spine hypermobility. Many times they're hypermobile, but they're not subluxed and stuck. but occasionally they extend and rotate too far, and then they get stuck in an extension moment. So now they're subluxed, but their baseline state is one of hypermobility. And the hip and the euphor, you need to think about the same way, is that many times these people will have an anteriorly translated hip, and it's going to put stress on the external rotators. It'll put stress on rectus femoris and the anterior hip capsule. So you get some anterior tightness from it going on. But the hip is not subluxed. So when you test internal rotation, it may be excessive, or it may just be normal. So in standing, what I want to see is can they, when I feel the greater trochanter, is it centered in the middle of the iliac crest? Chances are you're going to go and you're going to palpate her hip, and if it's let's say it's right side where she feels the hamstring, left sided hip, it could be either one. Either hip, one of those hips is probably anteriorly translated, and it could be more commonly medially rotated. So you feel that trochanter go forward and spin internally. So think of it as a continuum. People who wrote on that are mostly Shirley Sauerman, one person who I can't remember, Gail wrote on it, and Diane Lee. And those of you doing chapter 4 and 5, she'll address that in there as well in some of the hip gripping strategies. But understand that the manipulation and the euphor exists within that continuum. And you'll find that continuum in a great number of individuals. And then it's a matter of how do they get dynamic stability through the hip.
The chapter 4 and 5 you're referring to, is that only available to the fellows? Because I can't find it anywhere.
Yeah, you can buy the book. I just had them buy the book.
And it's just those chapters are the ones you're
I had the fellows read that because chapter 4 really kind of does a great job of summarizing like all the biomechanics that we've gone over in the slide with greater detail. And if you want somebody who really wants the references, going from Panjabi with form and force closure to Hodges and neuromuscular control, does a nice job in there. And some of the fellows I have them pulling out, she talk about classic patterns like back grippers and hip grippers. And did Eric address that, talk about those different patterns in Chicago?
That's the first I've heard of grippers. I don't know if
it's not widely used, but they're patterns of people who stabilize in certain ways. Mm-hmm. And it's not something that, well, your career is not missing something huge if you're missing it, but I like looking at predictable patterns because it makes life easier. If I see predictable patterns and I can fix predictable patterns, then I don't have to think a lot in my day. I can be dumbed down throughout my day and kind of go through stuff, and it's less draining. So the more patterns I can recognize, the happier man I am. And these are just some patterns that you'll see out there in different backs and people. If not, when I have the fellows here in Baltimore pulling these together and writing them out, I will punch them out to people when they finish that. But again, if you didn't go over it, you can't do everything in a weekend. Hey, Dylan, did you post the right book link for me this time? I sent everyone the book link previously, and I sent them the wrong one.
I just researched it up and made sure that we had it's this one.
Yeah.
The link should be this book.
Okay. Yeah. That should be the cover. That's good. And that's where it goes into hip centering. So don't let all this doubt yourself, Deb. Take what you've learned from here, go in there and apply it. And one thing I always encourage you is don't be too hard on yourself. Early on in this, you feel like you should get it all and it should all make sense. It's like I look at people and stuff doesn't make sense for a while. And then, 30, 40 minutes into it, there's this aha moment where, hopefully I can pull it all together. So as you look at her, just pull the information and collect it, think about it. Again, don't beat yourself up too much if you don't have it in 10 seconds, because there are very few cases that you do. So just be good to yourself as you learn it. I think it's the biggest piece of advice. I think too many of us just beat ourselves up over this.
Thank you. Appreciate it.
Oh, no problem. If I find something useful, I'll try and kick it over to you.
Okay.
Yes. All right, it's gone quiet. So let me do this. So we got a little off track with some of the presentations when went over some of Jim's cases, which I thought was great and worthwhile doing. Just off-centered some of what Jim was putting up as far as things. So one of the presentations that he put up not too long ago was he was talking about tibiofibular dysfunction, and at the end of that presentation, he just had some additional challenge questions. So I thought it might be good to take a minute and just look at thought processes. We can go over the diagram to make sure that makes some of the sense. But at the end of those, maybe take some time and go over those 5 situations that he put up there where he was asking different questions. And let me scroll down to it. I believe it's here. Where are the questions that he had? So to make it merciful for everybody, I was just going to pick on a few of the regular people that I pick on and kind of go over these in a bit. But before I do that, let me scroll up a touch. And let's just go over some of the kind of the slides and the decision grid that Jim was looking at, because this really is an insight into kind of, Jim's mind and the way to think about some of the testing, and that whether it's tibiofibular joint or elbow joint or wrist, in many ways, this mental process is very similar in what we're doing and looking at things. So, let's just look at, here he's talking about looking at tibiofibular biomechanics and, do I have pain at this joint? And really coming down to is, do I have pain at the lateral knee joint? And, with pain at the lateral knee joint, the first thing you're going to do is you're going to stress the joint to see if it's painful, is what he recommends. It's going to do with everything. Is, okay, where is it painful? You're going to stress to see it. And, if you find that this joint, you go and you kind of take the joint, let's say you mobilize it, you glide it, you compress it, and it's painful, then you know that, okay, I need to take a further look at this. And always keep that open mind that this joint could be anywhere in the continuum from subluxed or arthrosed to hypermobile and unstable. So what we want to be able to do is to go through and take a look at it and say, how can I determine, whether this joint is stressed and painful? So you follow down along here where you go to none. I'm going to go to stress, you're going to stress the joint for pain. And you stress the joint for pain and it's positive, then basically what you're going to do is you're going to look for gliding of the joint. Then you're going to take the joint and you can glide it. Gliding it in neutral is going to give you an idea of, okay, what is the motion state of the joint? So doing your joint glides in this one, and this can be anterior medial, posterior lateral glides, the proximal tib fib joint. You're really going to look for, is this joint stable, and subluxed, and i.e. restricted? Or, do I then have an excessive or hypermobile glide to it? It's going to be what you're looking for. So if I poke on this joint or I have pain centered over the joint, it's one of the early things I do is I'll go in there and stress the joint and see if it's moving. Am I restricted in this joint's glide? And it'll give me a good sense, okay, is this a stable subluxation? What's the mobility state of it? Again, we'll get into if the joint mobility is normal, then what I may want to do is then take the joint for stability test. I can put it, let's say in its closed pack position here, which would then be dorsiflexion of the ankle, essentially driving the fibula upward. And then I can do my joint glide again and see my stability test. If I do that, the joint should be far more limited in its range of motion. So if I find, let's say I go along in here, along the top course into where I feel a normal range of motion of the joint, I get into it and I do the stability test and I put the ankle in dorsiflexion, go to move the fibular head and it moves around and it's unstable, then I know that likely when I do my active movement tests, for the head of the fibula, I'm probably going to have excessive motion. And that's probably what's driving my pain. If I have a normal mobility, but I have hypermobility on my stability test, then I know that this joint is moving when it should be stable and I should be transferring load. So that idea that even with, okay, a normal neutral range of a joint, the stability test is helpful in showing, do I have an unstable joint, which may only present in weight bearing or loading. And the similar model works in the SI joint, where you may find that, hey, I am supine and I rock the ASIS anterior, posterior, and the joint mobility, it seemed normal or fine, or maybe even slightly tight, but when they stood up and I did single leg loading or the Portland test, they were unstable. That shows me that when the SI joint is loaded, there's a lot more stress through it. Is the joint then becoming unstable in the loaded position, when this occurs? So going from a tib fib joint where we're looking at the stability test to, the SI joint, it's a similar thought process that, okay, do I have this functional instability that can be occurring? Because, many times we just think of, oh, it's subluxed or not subluxed. But I think you'll see far more of these load transfer problems in stability and dynamic stability that occurs with these individuals. Muscle firing patterns can create this, whether, tensioning the lower leg muscles will stabilize the interosseous membrane and stabilize this segment. So if I have a problem with firing pattern or motor control in the lower extremity, that can have implications on the joint stability as well by tensioning through the interosseous membrane as we get in through there. So I thought this was worth kind of just briefly going over, just to get a sense of, as we look at joint stability, how looking at the ability to transfer load through a tib fib joint and assessing it is a similar mindset as if we were to look at an SI joint and knowing that, okay, can I determine, is the joint painful? Is the joint, subluxed? If it's normal motion, do I then have excessive motion if I test it in a closed packed position or loaded position, showing that this joint may be functionally unstable when under load, but relatively normal in testing in like neutral position. So these are good, and these are good on those harder to figure out cases where everything seems to be moving okay and the pain may be mild or moderate. We will eventually get into how these problems here create problems elsewhere. And that's where Jim got into in some of his challenge questions, talking about how this type of instability can create problems above or below in the ankle joint. And in here, real quick, kind of think about these tests, stability testing. You can think about being done somewhat in closed packed or full dorsiflex position for the ankle. Mobility testing is kind of that neutral joint glide. And active mobility or kinetic testing would be your toe raise, your squat test, your body twist test, to see how it does in these movement patterns and where you may see the instability. So understanding these motion states can give you a good bit of information, whether it's proximal tib fib joint, distal tib fib joint, SI joint, or even a lumbar L5S1 segment. Scroll down. Cool. Here's the list of fun. So Tanner Timmerman, you and I haven't chatted in a while, have we?
We have not.
It's okay, Tanner. I'm gonna make this relatively painful for you. I put notes down here for us, so we don't have to labor through this. Okay, Jim's challenge question. I thought this would be good too, just because you've done these on your own. I think many of you have done a great job with it, but I thought it'd be nice to be able to talk through them a bit and see, and just a thought process. And let's say if the superior joint is unstable but not nociceptive, what may it cause and to what tissue? So the first is getting into the mind of Jim, and we know the joint is unstable, but it's not nociceptive, Tanner. So what do you think that piece of information kind of tells us, or Jim is looking for us to extrapolate from the fact that we don't have nociception or pain?
Probably that you'll get some type of like reflex inhibition and not pain inhibition. I don't know.
Yeah, like reflex inhibition can be left over from pain inhibition. What you may be looking for here is it's non-nociceptive. So what I'm going to think about here is that it could be a segmental influence. The joints become unstable. More so, like me personally, what I would think is that this is probably was this a chronic degenerative type of thing? Because if you think about most proximal tib fib joint problems, it's if it's an unstable joint, it's usually a traumatic dislocation, usually a hit from behind, something in like a soccer play. If you're looking at a traumatic superior tib fib joint dislocation or instability, that's usually what it's caused by. So we have a chronic one. So you see that, does that make sense? That when you see somebody like this, yeah, there's not nociceptive, okay, one thing I would think of is it may be chronic. The other thing is, you're right, is, I'll think of the nociceptive pathway, is that more of that comment I'll talk about where you're looking at reflex inhibition, pain inhibition. When it's pain, within there, you'll have these other things. So, you can see that what would be happening. Let's talk about it from a spinal cord midbrain level. So I have pain or reflex inhibition happening. What's happening at this, in colloquial terms, not neuroanatomy terms, what's happening at the spine or midbrain level to this region?
Can you hear me with that one more time?
Sure. Kind of what's happening at a spine or midbrain level in this region where, okay, now all of a sudden we have let's say, well, first let's go with we'll talk about nociception because it's a little easier. At the nociceptive level, we're getting pain coming into this segment. What happens, at the spinal cord level if I have nociception? What would you expect to see if I have pain coming in, which is number A in what's on the screen?
I guess you'd see like pain inhibition. Yeah, you'd less recruitment.
Yeah.
Less firing. No anything.
Yeah. So early on you have pain inhibition because you have nociception. Reflex inhibition you get left with later. So it's fair to say that you're going to have an altered recruitment pattern around this region, correct?
Yeah.
Yeah. And I think of it as a dimmer switch. And it's like your body hits the dimmer switch and you're not going to get full power to this area. Goes on. What also happens, that's why I like to kind of think about what's happening at the spinal cord level, because you'll get changes in inhibition, whether it's spontaneous inhibition, it's reflex inhibition that occurs there. That's why wobbling the segment or wobbling the joint can improve it. Altered motor planning. Now this is different. This is the concept of, you're familiar with the concept of cortical remapping?
Yeah.
Is that a yes?
Yes.
Yeah. So, with long-term nociception things, and they see this happen very quickly, let's say if it's Achilles tendonitis, is that you get cortical remapping at some point, where actually at the cortex level, how you motor plan will change in multiple areas of the brain. And for some of these cases, it can be a timing issue. It can be the muscle recruitment patterns. Most research has probably been done in back pain. The second most has probably been done in Achilles tendinopathy, looking at some of these cortical pathways and how we remap and change the firing patterns. So the nociceptive pathway, especially, you're probably going to have this cortical remapping. I'm not so sure about in a non-painful way. I imagine you probably would, but it'd be a little different. So with a unstable superior tib fib joint, the nociceptive pathway, I can think about having reflex pain inhibition occurring at local level. I can have altered motor planning and cortical remapping occurring at a more central level that can occur, as well as any pain sensitization that may occur in that region. That can be peripheral. Central. Does that make sense?
Yeah. That makes sense.
So I like to, it's just nice to break it out and think about, okay, these are, I'll try to pull up the diagram that shows it. If you can kind of lay it out in your mind and think, okay, nociception, I kind of can think about it this way, to some degree, nociception and, no pain will overlap a bit in many of these processes that you see, but the pathway, as Jim and what they look at in some of the pain sciences, they look at it, defines it this way. So think about no pain. If I have no pain, what we're probably looking for here is that it's kind of like if you tear your ACL completely, you generally have less pain is what you find. Zach can probably speak to that for us. Versus if you have some residual fibers and then you tear them, it's more painful. But what you have is decreased proprioceptive and signal coming in. So if you have no pain from this, what it tends to tell us is, what we talked about before, it's probably a little more chronic in nature. And there is, okay, is it because you get this altered proprioception coming in from here? Do you get more segmental facilitation, altered motor pattern, and altered proprioception? And altered proprioception is an interesting one because when the proprioception or loading force is different, we're probably going to recruit muscles slightly differently and change our balance reactions because we don't have stability through a joint we normally have stability through. So that idea of this altering our movement pattern, because of this instability to generate knee pain, because now we're not stable with this joint, it's shifting. So do we load the pain? Do we get increased dorsiflexion because of the instability being caused here? There. So within pain, you're going to see, and that's where you look at these questions of, when you have the pain in the superior joint, whether it's nociceptive or non-nociceptive, I'll think about these two different pathways, the pathways of pain that occur, where pain is going to cause pain inhibition, reflex inhibition, probably more likely going to have motor planning, cortical remapping, pain sensitization, whether it's peripheral or central. Whereas with no pain, it's probably more proprioceptive. Is it more going to create a segmental facilitation? Do I have this chronic degenerative breakdown that's occurring? And is there a stressor somewhere above or below it? Does that make sense? So Tanner, so here's the fun one, Tanner. Above or below it. So now we have what may the superior, let's just talk about instability of the superior tib fib joint. And what may it cause to what tissues? It's kind of overwhelming at first, isn't it, Tanner?
Just a little bit.
Yeah. So I allow myself to feel overwhelmed for about 5 seconds, and then I kind of settle down. Let's think about above it. What attaches to the tib fib joint, or what attaches to the fibula? And runs up to the pelvis.
You got biceps femoris.
Yeah. So let's think about above it a bit. Let's think about biceps femoris. So if I have an unstable base for this muscle to attach to, what might it do to the biceps femoris? And every answer is going to be
yeah, it could increase it could become hypertonic to help stabilize.
Yeah.
Could also be hypotonic because that joint is unstable. It just kind of would depend, I guess.
Mm-hmm. Yeah. So both would have implications. But let's think about the hypertonic one for a second. Where does biceps femoris attach?
Blanking on the specific.
I know it's so tough to get asked these questions. Think about it this way. Where does it, as the biceps femoris is one of the main ones that comes up and blends into sacrotuberous ligament, i.e. Deb's patient. So if I have biceps femoris coming in and it's going to attach to ischial tube, it's got fibers to varying degrees blend into sacrotuberous ligament and some of the even back into the dorsal fascia and the lumbar fascia. Think about the slings crossing over to the opposite side if you want to take the fascial attachments all the way up through there.
Yeah, so you'd have altered isn't it posterior oblique sling that you have that would probably be inhibited a little bit?
Yeah. So could you have unstable right proximal tib fib joint implicating some issue at the sacroiliac or pelvis? Your answer is yes.
Yeah.
Yeah, correct.
Sorry, I wasn't sure if you were asking. Yeah.
So think about it as it comes up here. So you can have, it's going to change the motor pattern. Now, the further we get away from a joint, of course, the more unlikely it is. But if you have a tight hamstring, hamstring is going to create tension through sacrotuberous ligament. It's going to stabilize the pelvis as a secondary stabilizer. So somebody with a problem getting forced closure elsewhere likely have again irritated or hypertonic biceps femoris going on. Glute could change glute firing patterns and kind of facilitate in there. So scrolling back up to Jim's question again, what may it cause into what tissue? I'm going to take this a little bit further and be a little bit more elaborate. You can see how this could kind of come up here. And now all of a sudden you're up into the pelvis with a pelvic issue, because now you've altered biceps femoris firing pattern. And now you have hypertonicity through biceps femoris, pulling through sacrotuberous ligament. In lab yesterday, it's one of the things we did is I had people palpate the SI joint mobility, find the R1 or just the neutral zone of the easy motion of it. And you contract hamstring and you feel that it's going to lock down the SI joint and create force closure. So it could be a secondary compressor of that joint. And Deb may have to deal with something like that when she sees that individual. That, okay, do I have something going on there since they have hamstring irritation? So Deb, the first thing you look at won't be the proximal tib fib joint. Okay, this is kind of down the line of what you look at. So don't think that person is going to be a proximal tib fib joint. But if you have time at the end, it's worth taking a poke at. But I wouldn't.
Start with the big toe.
Yeah, exactly. Don't get too far away. Stick with where you are, and then second session, I work my way down. So from there, I have like inferior joint here above, hamstrings, sacrotuberous ligament. I'm into the SI joint. I could be looking at glute firing pattern. This individual could have a hip that is anteriorly subluxed situated and not centered. And this hip is, now, anterior subluxed or medially rotated. It could be off. All these things could have implications in compression to the lumbar spine and how the lumbar spine moves. If I have a hypertonicity in my biceps femoris and I go to bend forward, Tanner, what is likely to happen in my strategy? What's my strategy going to look like if I have a hypertonic biceps femoris?
You would probably stabilize through that first.
Yeah.
You're kind of breaking up, so I'm having a hard time kind of catching some of that.
Oh, I'm sorry. If the hamstring is hypertonic, when you bend forward, what's your likely strategy?
It'd be more probably hip strategy. I'm not really sure.
Yeah, what's going to happen is that this person's going to have a lumbar strategy. So instead of having the pelvis tilt forward, they're going to use lumbar spine, thoracic spine, most likely, because they have that hypertonicity in their hamstring. They're likely not just inhibit the hamstring. So you'd see a pattern there where it may go on. So that's, if you're looking at above issues, that's taking it a couple steps further. You won't need to do that if you do an answer like this, but it's just nice since you just did the pelvis. I thought it'd be nice to do a pelvic one where you can see where I find something going on in biceps femoris. What are the implications in the pelvis, and what could potentially be something that I see below it going on? And since Tanner's sound breaking up, Drew Albers, you out there?
I'm here.
Cool. So you've had a few minutes to think about this. Let's go below now. What could be one of the things that is going to impact some of the tissues below the tib fib joint, proximal tib fib joint? I put a list here. We can just, from B to E, we can kind of go down here and think about what will be the implications that may occur if I have a subluxed or a hypermobile and unstable proximal tib fib joint.
You have an inhibition of the peroneals.
Yeah. You could see changes in the muscle firing pattern. And you couldn't have given a wrong answer here, quite likely. Because if you think about it, when you fire the peroneals, there's most of the muscles that are attached to the interosseous membrane, they're going to stiffen the joints. So you get stiffness in the interosseous membrane in the joint glides when these muscles are hypertonic. So you could have inhibition of these muscles occurring from reflex inhibition or pain inhibition. It's occurring around it, or altered motor patterning. You could also have shunting of these muscles, where now all of a sudden your body's trying to seek stability. So it wants stability, so it knows, okay, if I clamp down the tone in these muscles, do I now have increased stability of this system, locking it down? So that's where it's keeping that open mind of, do I have an under recruitment pattern that I have to see maybe dynamically? Or do I have this hypertonicity, which now shows up when this person runs or does an ordinary activity? Or they, rolling their foot in there because they have this increased tone or this shunting that's occurring. So what about nerve? Is there any nerve that would be implicated here?
The common peroneal.
Yeah. So you could have neural sensitization, neural changes if it's getting there. I believe most of the subluxations that occur at this joint and instabilities are anterior, because I believe the posterior ligament is much stronger. So less likely to potentially see that. But it is definitely something, if this thing is, unstable, that you could have going on. It's there. How about joints below it?
The talocrural joint.
Yeah. What do you think would be happening at the talocrural if this joint is unstable? So we think of normal, like in walking gait. What would likely happen?
Would you have less dorsiflexion then? And
If it was unstable and hypermobile, would you expect to see less dorsiflexion?
or more?
Yeah, you could potentially see more, unless it's subluxed,
Okay.
because it
And
could.
then would you see this where they would start to do this toe out potentially then, if they're not getting great recruitment there then with the peroneals?
Yeah, it's really kind of a common pattern, don't you see, where the hip is laterally
Mhm.
rotated when they want to get
Yeah.
around or not transfer load through it. Tends to kind of shunt what we need to do. So potentially, yeah. What you may see here is that because you're getting an increased anterior superior glide with maybe end range dorsiflexion, is that you can actually kind of see this break down in that way. So would you see increased dorsiflexion or hypermobility in that if they aren't able to shunt that motion, because the fibula distally may be slightly unrestrained. And again, it's going to change some of the patterns. The fibula, as you go in that gait, as Jim talked about in the video, it needs to rotate an 80 duct. So it can change the angle of rotation. Typically, like with the gait cycle, the talus pivots usually around the tibia, and the fibula goes along with it. So the fibula isn't an axis; it kind of moves along with the talus. Now, in some cases, if you lose that axis, then it gets off, and the axis changes to the fibula. But that's usually with a deltoid ligament sprain. So yeah, so what you would see is problems probably at the talocrural joint. So I expect to see. If it's destabilizing as you go through here, then you have failed load transfer. And if you're unable to then find stability as you roll into that dorsiflex position, it may alter, gastric soleus activation. You can make up a myriad of muscle situations that may get altered depending on the strategy that they use. But I would expect breakdown into dorsiflexion. Or what you may see is in gait is maybe an early heel rise, because they're not stable. They can't transfer load properly in the late stance. Does that make sense?
Yeah.
So you have, articular dysfunctions. And then, neurophysiologically, that's kind of where Jim's going with this, is neurophysiologically, what might this joint might happen at this joint if I have a unstable superior tib-fib joint. So neurophysiologically, there we're talking about, pain inhibition, reflex inhibition. We're talking about segmental facilitation potentially if there's if we're talking, Jim will talk about that being more proprioceptively involved versus nociceptively is more the pain and reflex inhibition versus segmental facilitation. But I also think this overlaps with a bit of sensitization that goes on. But you're probably going to create problems down the distal joint because it's going to change its stability. That makes sense. All right, Drew, one last one here for you three, and then we'll dump 4 onto Tanner Newberger, which is going to be, again, you have, with this, what would be 5 differentials that we can think of for lateral knee pain?
You could have obviously superior fibular dysfunction.
Differentials. That's what we think it is. What are 5 other things?
Okay, 5 others. You
Go
could
through the
have,
thing, think joint, muscle, nerve.
and
What else?
LCL.
Yep. Because this is going to be stressed with
Do we
this.
want to say grade 1 tear severity?
Mhm.
You could have a lateral meniscus.
Yep.
You could have a distal IT band.
Yep.
You could just have a lateral tibiofibular arthritis.
Mhm. Think about it. You have joint, you got muscle, you got tendon, you have ligament, you have nerve.
Oh, you could have a coronoid, lateral coronoid ligament.
Oh, I like it. Anything refer to the lateral knee?
Maybe a plateau fracture.
Yeah, but you have a history of trauma for that, so it's less likely.
Okay.
Yeah, you're gonna put fractures in there. You can.
Okay.
Yeah, and you can just think of, okay, do I have referred pain? What a referred pain may look like if you have something coming down, and it's not an odd spot for it, but and usually if you have a lateral meniscus tear, oftentimes in the lateral knee, what you'll see is a cyst. Often you get a cyst that comes right off of the lateral meniscus, and it looks like an IT band bursa swelling. That's usually pathognomonic for a lateral meniscus tear. But no, you got to the 5, that's good. Yeah, Jenna, hamstring tendonitis. So often when I see it this distal, I would think, okay, I have something probably with the fibula, or it's a dynamic issue that's stressing it. And or posterior, if I see hamstring irritation this distal, I often look for a Baker cyst, because oftentimes you have something going on in swelling, intra-articular swelling, which seems to irritate the distal hamstrings. There, but it goes in there. Good.
Dave, real quick, when you're talking about referred to that specific location, what types of things are you thinking of? Because when I think referred, I generally am thinking more generalized and not as specific to the lateral knee.
Yeah, I can't really think of anything in the lateral knee. That's kind of why I'm asking. I mean, you can have general,
Okay.
you can have something like an L4, L3, maybe wrapping around there, giving you something.
Would you expect that to be specific to the lateral knee, or would you tend to see more of a general span of that pattern?
I'm sorry, can you say that again?
Sorry, I got a phone going off. Would you see that specific, if it is referred from kind of an L3, L4 level, that there would be more of a general pattern down the leg rather than specific?
Totally expect a general pattern.
Okay.
That's why I kind of left it kind of vague, because I couldn't really think of anything. I think, well, maybe I'm missing something in my mindset. What else would refer just to the lateral knee? Unless it's just a cutaneous neural irritation, but there's really none that I'd really see there. Unless it's just been sensitized by something happening at the lateral knee. So to cover something there would have to be something that I would expect to be more wrapping or banding. If you're looking at a referred from the lumbar spine, it wouldn't be specific to the lateral knee. So I agree. Good. Now we have lightning round. Tanner Newberger, you got 5 things for anterior ankle pain. Oh, Tanner's gone off to get a drink of water or go pee. That's unfortunate. It's unfortunate for Dylan.
I'm here.
Oh. What have you got for me, big guy?
So anterior ankle pain, correct?
Yes.
We could just see that anterior talus subluxation. You could probably see extensor hallucis tendonitis, even tenodesis, well, not tenodesis, but tendinosis, correct?
And where would that be in the anterior ankle? What would cause that?
The extensor hallucis
Irritation under,
there.
irritation under the extensor retinaculum.
Okay, yep.
Generally, you'll see anterior tib, anterior, or the extensors get irritated when they're levering through it. Say a weak anterior tib, or they're overusing it. Generally irritates it on the extensor retinaculum. Yeah. Cool. What else? Ligament, tendon, muscle, articular, neural.
We got anterior tib that can contribute to that, especially if you do have a neurological injury going on, whether it be a peripheral nerve or a segmental portion of it that can lead to that foot drop and less control through there.
Yeah, same thing. Anterior tib would irritate the extensor retinaculum. I'll give it to you.
Yep.
What about if you've had a chronically torn ATFL? What happens?
You get instability in that joint, so
Mhm.
other structures have to come in to try to compensate for that.
Scar tissue plica. It creates a mass effect on an anterior joint. Same thing would happen if the anterior tib fib joint was degraded and broken down. You can see something very similar with that. An instability. That may be a differential here.
What about unstable mortise?
Mhm. Yeah. And so yeah, and anything here like a neurophys or segmental facilitation, reflex inhibition, any of those things would be etiologies, not a pathology. And what in the bone? We have instability. Like again, we're getting further down the list of potentials. So Jim, in that one conversation, like, here's my top 3. All those other things are like number 10. And it's okay to go down to number 10 because you want a long expanded list, because quickly in your mind, you rule them out. So depending on the age of the individual, what you may see is like an OCD or an osteochondritis dissecans, maybe further way down my list. But in the back of my mind, I have a illness script for it, just so that I don't miss it. And if I'm running out of things to answer in a practical, that may be something you kind of put in there. It's just kind of just the thought process, like even like in practical, as you can see, is just, it's not so much just practicing a practical. This is a good mindset that in your mind, I may have these, I have anterior ankle pain, I'm going to look at all these are all the structures that are in the back of my mind, and I have a ready illness script for it. How do I tease through these different things, whether it's a biomechanical joint subluxation, an instability to ATFL, or anterior tib fib ligament, I can test stability. I can palpate and look at extensor hallucis longus, or extensor retinaculum is getting irritated. You can look at biomechanical dysfunctions. Again, osteochondritis dissecans. This is a younger athlete that's doing this. This is an older person where they have degenerative breakdown of a joint. So it would really depend on who I'm looking at, whether I'm looking at OA, osteochondritis dissecans of the talar dome. It's going to be a subset of individual. It's a little different. So not my first thought, but it would be down the line in my bias correction, what I might look at. But like everything in practical and seeing patients, it really helps to have these little ideas in your mind that you can work through this, because you can move through these things kind of faster and efficiently and kind of get into looking for these problems. So that's pretty good. So I hope this helps. I hope it just gives you kind of a mindset of looking at Jim's questions and just how to think about them and approach them. Cool. Sorry, I ran over a little bit on people. Cool. Hey, Tanner, and Drew, good job. It's hard to answer these questions on the fly like this. So I know how hard it is, so I appreciate you guys doing this. Other than that, I think I am